Well, Tracy asked me kindly to give another talk to you on this occasion, and she was aware I'd been affected by the world's latest virus, and I said, well, I can do my best, but I haven't read a scientific paper since I signed one off on the 29th of February, 2 days before I became symptomatic. So I said, I'll go back to what I did back then and see if it rekindles something. So that's my header slide from 6th of April 2019. And so we get to where we are now. I happen to now be, you probably see, President of the Association of Clinical Pathologists. So I am one of the 38 recognised presidents of pathology in the world. And we have a little group called the International Liaison of Presidents of Pathology. I've left the NHS, but I haven't retired from medicine. So I'm now an honorary consultant to St Mark's in London and St Vincent's in Dublin, the national colorectal centres in those countries. I'm still associated with Cardiff University, although whether they think I am, I'm not sure. I'm a member of Council of Insight and the UK Cancer Genetics Group, which coordinates things to do with cancer genetics in the UK. And, of course, I'm a medical advisor to Lynch Syndrome UK. Right, so here's just a quick slide about Insight and what we do, and we have links to all the different syndromes that cause hereditary bowel and other cancers, as well as sundry other things. And we were due to have our every other year international meeting last year, but of course we had to stall it, so it will be in September this year in New Jersey. So if you can make it, you're welcome. So progress since 2019. Well, we're understanding more about how and why do bowel cancers occur in Lynch syndrome, and getting there also with endometrial cancer. We started off with nice guidance on testing every bowel cancer. That's DG27. That took 17 years in the offing. And we've now got DG42, which is systematic testing of all endometrial cancers in place. And I'll talk a bit on getting that right. More is coming. I should explain. The way this has hit me is that I can see the word I want, but I can't see it. I can see all the words around it. Okay, so if I stop in mid-sentence or stall out or sort of stutter, it's a bit like MSI with words. Right, okay. So Lynch syndrome in the immune system is really coming to the fore. I can talk about the work I'm doing with the World Health Organization on cancers and Lynch in particular. John's going to talk about aspirin later, but at the UK Genetics Conference a couple of weeks ago, there was a fantastic talk by a student in Leeds, Kelly Lloyd, on the ways in which aspirin is or isn't presented to patients or offered by doctors. So we'll show that later because she can't be with us today, but she's very happy for me to show her talk, which fortunately is recorded online. So at the end of February 2020, I caught this new virus and suffered COVID pretty badly. I wasn't admitted, but I would be nowadays because everyone on the radio was saying it's mild, and the only case near me in Wales was 30 miles away. Well, there weren't. There were a hell of a lot of people at Cardiff railway station the day I caught it. So in that time, I've learnt a lot more about the immune system on a pretty sort of personal, physical basis. The disease we now call long COVID because I got it before it was named. In fact, I know the Italian doctor who named it, and people don't spell it right, okay? People who think you know. There's lots of people around who think they know what we've got. And I have to say I'm somewhat embarrassed to understand now more as a patient how you must feel being dealt with by people who are just plain ignorant, stupid, think they know better than you do, and don't listen to you. I hope I was pretty good with that before, but it's been brought home to me. And this specific lexical retrieval difficulty thing. So I was one of the first subjects studied by a professor who studies language difficulties. And she interviewed me on Zoom, which is apparently the most fantastic way to bring out ways in which you don't speak properly. And she reassured me very quickly, no, Ian, you're not demented, because all your words are still there, you're just having difficulty getting them out. And we see that in people who've suffered injuries to their head. So we'll crack on. So in terms of how and why do bowel cancers occur in Lynch, I published this review with some esteemed colleagues, and you'll see there it was accepted the 3rd of March 2020, which is the day I became symptomatic, although I didn't realise what I had at the time. And I signed it off on 29th of February, which is Rare Disease Day. I thought that doesn't come along very often, so I'll do that. Just as well I did, because I was sort of rather hammered from then on. But I should explain that this was an invited review, so quite prestigious, and there's a lot of words in it, but I'll try and summarise it with some pictures. So this is a picture I start off with when I'm training doctors and counsellors and people. It's a piece of human large bowel which has been opened up, and we're looking at the inside of it. And just there is an adenoma. It's a polyp. It's a little blob sticking up from the surface of the lining of the bowel, which normally should be smooth. It has all these folds in it because the bowel expands and contracts, so it has to kind of concertina. But that's an adenoma, a benign tumour, and there's a cancer which has arisen within another adenoma, and that's the usual pattern we see. If you look, there's a ruler at the bottom, and it's up to 6 centimetres to give you an idea of size. So that adenoma is about 5 millimetres across. And I make the point that precursors to bowel cancer other than adenomas are available, because by studying Lynch syndrome and other conditions, that's what we understand now. 20, 30 years ago, we thought everything came from adenomas. But you'll see that, yes, but it's a bit more complicated than that. And that's thanks to some of these fantastic guys who work at the Institute of Pathology in Heidelberg in Germany. And there's a picture of Matthias Klau and Azel Hardover. And the last time I saw them was at the European Congress of Pathology in 2019. And Matthias was his usually ebullient self, and he rushed out of the Congress hall and was frantically making a call, trying to ring Azel. And I said, what's with the rush? She's not your wife. And like all Germans come out with, he says, no, but she soon will be. So that was quite a nice occasion. So what did they discover? They discovered, while looking at the lining of the human large bowel in patients with Lynch syndrome, that every now and again, one of these little crypts, these things that look like a slice of orange, does not express the protein that is mutant in the person corresponding to the gene that is mutated in the person who has Lynch. So the stain here, the red stain, is for the intact protein. And where it doesn't happen is where you see that little blue circle. And this is a rare event. There's about 1 of these in every square centimetre. And there's about 400 of these little crypts in every square centimetre. So it's the needle in the haystack. And there's a square metre of the inside of your large bowel. So it means that you have 10,000 of these little things in your bowel. And the question was, are these what give rise to cancers in Lynch syndrome? And if so, if there's 10,000 of them, how come you only get no cancer, 1 cancer, 2, 3? Why does it differ by? But at least we had the clue that here was something to chase. Now, if you look at the surface of the bowel from the top down. So at the top of this picture is the inside of the bowel, and at the bottom of the picture is the wall of the bowel. These little tubes that we were seeing down from the inside of the bowel, if you look down, this is about 2.5 millimeters. This is the mucosa, the lining. This is what the colonoscopist looks at from the top. And these little pits are what's called crypts. And the cells divide in the bottom and they come out of the crypt. So there's a schematic diagram of a crypt. And if you cut across it, that's why you see it cross-cut. It looks like a little ring. So every now and again in a Lynch patient, there's a crypt that has lost the DNA mismatch repair protein corresponding to the gene in which you have a mutation. Now, almost all of your other cells express that protein because you have one good gene and one that has a mutation in it. So this represents a crypt in which the stem cell at the bottom has had a mutation in the good copy, and so there is no protein. So it's started a process going. And as pathologists we ask, well, what process has this set off? And just to finish off, here's what an adenoma looks through when you slice it through. It's a blob. The cells are overgrowing and they can't go outwards, so they go up like that and form a polyp. And you can see that the cells are not normal. This is irregular compared to the nice, neat normal. So there's changes happening. The cells are becoming abnormal. But they're not cancerous. They're just a bit on the way. So we summed up a large part of our review with this diagram to illustrate the sort of state of knowledge. From a crypt, normally, in most people, in anybody, including patients with Lynch, you can develop adenomas, like I showed you in that picture. Anybody can get those. That's why we screen the general population and take them out. And that happens because of mutations in a gene called APC. And if you're born with a mutation in APC, you get hundreds or thousands of polyps. We call that familial polyposis. So we know this very well. So just because you have Lynch doesn't stop you getting adenomas. But it's a question of what happens when you do get an adenoma. Well, through the work of Azel and Matthias and others, we now know that then those can lose the DNA mismatch repair protein corresponding to the one that you have mutated. And it is different depending on the gene that you have. It's most likely with PMS2, and it's least likely with MLH1. So, so does this start to explain why there are differences between people with the different genes? So that's quite interesting. And that then leads potentially to a cancer that has lost mismatch repair, and we called that a type 1. So Lynch syndrome has not caused that adenoma, but it has caused that adenoma to turn into a cancer of that sort. So does it or doesn't it cause it? Well, that's an interesting little sort of philosophical debate, isn't it? We occasionally see cancers of any sort that can occur in anybody in patients with Lynch. And they're not the sort of cancers that classically are part of Lynch, but nonetheless, they lose mismatch repair. So I've seen thyroid cancers, we see breast cancers. They're not due to Lynch, they just arise in Lynch, and then because you are that way inclined, those tumours become mismatch repair deficient. So that's interesting. Let's just park that as interesting. Point is, these are polypoid cancers. Now they're pretty easy to spot when you go doing a scope. The next sort that we recognise is where we have one of these crypts which has lost mismatch repair. And we only see those in patients with MLH1, MSH2 or MSH6. They seem to be phenomenally rare in PMS2, if indeed they occur. I suspect they do, it's just a question of they're just right off down the other end of that spectrum. And the thing is that if those then have mutations in other genes, they can then become a cancer, which has lost mismatch repair, and they're the flat ones. And Azel actually found these lesions hiding under the mucosa, flat ones. So they're very difficult to spot on colonoscopy. They're not impossible, it's just that the odds are much less. And we recognise that, and that is peculiar and specific to Lynch syndrome. Now, there's a little twist in the tail here. You might have noticed because there's a bit of the picture missing. Some of these flat ones can acquire at a later stage a mutation in the APC gene, so they become polypoid. They suddenly stick up like a mushroom in the autumn on your lawn. And they become a mismatch repair deficient bowel cancer, which is polypoid, but they started flat. Now that's sneaky, isn't it? And that is a Lynch-specific mismatch repair deficient adenoma. Those only occur in Lynch syndrome, and they are different from your common or garden adenoma, which is the type 1. And how did my friends in Germany work that out? Well, they looked at the precise mutations that had occurred in APC. And the ones in type 1 are the ones we have a huge database of, that we know what sort of mutations we expect, and it was those sorts. But the ones in these type 2s are the mutations you would predict in a tumour that has lost mismatch repair. So they are distinct and different from the type in 1. They go for the same gene, just in a different way. And they can occur after this one CTNNB1 has happened. So we know that it's gone by a different route. It's gone, round the outside and ended up in the middle of the town, not gone straight for it. So we understand now that this varies depending on which gene. It can give at least 3 different sorts of it can give cancers that are the same, but they've got there by 3 different ways. And it depends on the gene, so we can start to understand and develop and understand why this, that or the other treatment or process of surveillance works more or less better. So just like to go on now to the process of getting it right, which is something dear to my heart. I like things to be precise and exact and proper, and if you want a career, do it in pathology if you like, that sort of thing. So how do we assure that laboratories get it right? Well, you need to do things according to a gold standard, some sort of established standard that everybody can refer to. Otherwise, everybody gets the right answer, but it's only right for their lab. It needs to refer. So we have gold standards, we have a standard kilo, we have a standard meter, etc. So for doing the stains on tumours, such as I've been showing you, there's a reference panel that we have in the UK in National External Quality Assurance Scheme. So we send out the same slide, we can section it hundreds of times, to all the laboratories that have asked for it, and we ask them to stain it and send it back to us, and then 5 of us round a multi-headed microscope all score the same slide and give it points depending on how good it is, or sometimes how bad it is, and that we must fail it. So that's external quality assurance, and a laboratory within itself does quality control. So it does tests within a batch of tests to make sure it's getting it right, but they refer ultimately to what they do. They also send us slides from a section of a tumour they have, and they stain it with their method, and often we can see that they are better at staining their own sections than they are at the ones we send them. Well, that's fine, we accept that, because they've probably adapted theirs to their local conditions. If you've got a laboratory in the Middle East, it is probably 5 or 10 degrees hotter in there than it is somewhere like freezing cold like Newcastle. So we've been monitoring how many laboratories participate, and these are laboratories from all over the world, but about 2/3 of them are from the UK. So way back in 2012, which is a couple of years after we started, we had 63 labs participating, and we had 95 by 2017 when the guidance on bowel cancer came out from Lynch, And so there was a rise in the number of laboratories who needed to participate, because all NHS laboratories must participate in this scheme if they offer this test. And all of a sudden, they had to start doing it, so they had to participate. What was interesting was that in 2020, the NICE guidance came in on testing all endometrial cancers, and it specified they needed to use immunohistochemistry, and boom, it's gone up. So there was 168 last year, and it's growing. I think there's about 185 now. So this is a real result, because we used to get everything done in half a day. Then it went to a full day. Then it was getting a bit busy, and then we've had to expand to spend 2 days in London. And during lockdown, that meant going on a Wednesday, Tuesday, Thursday, Friday, and then coming home on a Saturday. But that's great. We get loads of stuff to enjoy and assess and make sure and give advice to labs on how to get their staining good. So is the staining getting better? Well, these are the 4 different markers that we assess, MLH1, MSH6, etc. And the green line is the acceptable line. A laboratory has to be over that line, otherwise they get a red flag and they have to make things better. And when laboratories started way back when, quite a few of them were just below the borderline. But you can see that the performance is creeping up. Now that's because they're getting better, we're getting better, and the antibodies that are used to do those stains are being improved. Manufacturers realise this one doesn't work, so we'll get rid of it and replace it with another one. So the whole thing is getting better. And the slope might not be high, but now almost all laboratories that participate do satisfactorily from day one, whereas previously it was, you need to, amend this or improve it. So that's good. Labs are getting steadily better. So just to come on now, what do we got? Oh, bit of time. About the immune system. So the immune system is a dispersed thing all over you, and it's extremely complicated. People talk about, reduction in immune function, yes, but lowering one bit raises another, because it's all got loads of little balances and cogs and stuff. And it's found all over us, because it has to be. It has to defend us all over, but there are places where it sort of gathers. Lymph nodes, which I'm sure many of you learned about, they're like sort of little Roman forts containing lymphocytes, ready to sort of rush out and do stuff, but they all talk amongst themselves in there. The spleen, which is a thing over here, and that filters the blood. It's like a ginormous lymph node that's specialised in doing blood. There's Peyer's patches, which are sort of flat lymph nodes but in the wall of the bowel, and they're all secondary lymphoid organs. So they're places we can single out. Interestingly, the lymphocytes that make antibodies, if you gathered them all up and put them in one place, they'd form an organ the size of your brain. And I didn't realise that, but you realise, this here and there. Right. So it's evolved to protect us from external insults, so infection, injury, and internal insults, which come in the form of tumours like cancer, autoimmunity, so the immune system attacking itself, so there's all sorts of controls to stop it attacking itself, and babies, which are huge, 50% abnormal tumours, right? Because they've got the genome from your partner. And ladies' immune systems are designed not to reject a baby, but to reject other things. So, that's difficult. So there's many different cells. There's lymphocytes, as I said, some that produce antibodies, B cells, and T cells of umpteen different sorts. Neutrophils form pus. They only last a day. They're fire and forget. They come out the bone marrow, last for about a day, and then die. Lymphocytes last your whole lifetime. There's mast cells that are to do with parasites, but if they don't have a parasite to deal with, they'll give you an allergy. And then there's monocytes, large sort of interesting things that crawl around. Once they get into the tissue, they become macrophages, which is Greek for big eaters. So they gobble up gunk and destroyed cells and whatever. And then they go up to a lymphocyte and say, here, what do you make of this? And we've come to understand that monocytes do some really weird stuff. And that has come about because of studying people with long COVID. We have abnormal monocytes. We have too many. They're doing weird stuff, things we didn't know they should do. So it's all very interesting. And I get a daily dose of immunology from Professor Anne Ager, because those of you who know, will know that this is Mrs. Frayling. And she's a world expert in how T cells get around the place and how they know how to come out of the blood here and not there. So that's very useful, actually. Well, almost too useful. After I've been clobbered with acute COVID, she's scrolling down a smartphone, says, COVID has the immune hormone profile of flu and malaria combined. And I'm thinking, having recently got out from under a steamroller, yeah, that figures. So anyway, that was my antibody result, 30th of March, just after lockdown, you remember? So my antibodies were coming up. The lab that produced those was interested in what level I'd got, so a month later they found that they could dilute me out to 1 in 5,000 and I was still coming up positive. So 1 ml of my blood would make somebody not immune appear positive, which is pretty impressive. And once they knew that, my wife's department got onto it and they filtered out my T cells. And if you look in the bottom right-hand box, there's P1 and P2. Those are T cells specific against SARS spike protein. Each one of those individual cells was sent off to Oxford to inform vaccine production. So although I couldn't function as a doctor, my cells could help in the medical system, if you like. Blood transfusion had 1.2 litres of plasma off me. I went to have a nice day out in Bristol with the excuse to cross the bridge and get out of a sort of enclaved country. And my mate who produces the test said, "Do you realise how much that's worth, Ian?" Because he sent me a line from a plasma broker in the US who was offering plasma with my level at $50,000 a mil. So I donated $60 million worth for free. You know, that's the NHS, that's how we do things. And it also went to the synthetic antibody production in Oxford that was given to a certain Donald Trump, off ticket, out of trial, on compassionate grounds. So I tweeted it may have imparted some immunity to him, but it hasn't imparted any social responsibility. A year after having it, my spleen was still enlarged, which is pretty impressive. I also had liver damage, pancreas damage, and a third of my right lung was taken out. We later found out that I'd got clots in my brain. But just before I was immunised, my antibodies were taking 7 minutes to come up as opposed to instantaneously on the lateral flow. 2 weeks later, they were back to instantaneous. So goodness knows what they were after the second one, which was about booster number 10. Anyway, so Lynch cancers have a lot of immune response in and around them, and they produce these things called frame-shift peptides. So a protein spelt normal might become Normans, which in the context of 1066 could be critical. And what we see is lymphocytes around these crypts that have lost mismatch repair, and they're obviously doing something. They're sniffing them out, and they're reacting to these novel abnormal proteins and producing antibodies and T cells like they found in me to spike protein. And the number of these crypts creeps up with age so that there's more of an effect. And what you find in people who haven't had cancer is they haven't got these T cells that respond to these kind of proteins that you get in a Lynch-type proto-tumour. And in somebody who's got an ordinary sort of microsatellite stable tumour, you don't find them either. In someone with a mismatch repair deficient tumour, you find them. And that's both Lynch and sporadic tumours of this sort. But what you find in Lynch patients who've never had a cancer is that they have the same response, showing that something is going on in the body, and it is probably these little crypts that are deficient that are immunising you as you go along. So the thought is, if they produce a vaccine, maybe they could get this immunity better earlier. And that is in development, and there are trials ongoing. But how do cancers grow out? If there's so many of these little crypts, how do they get out? How do they escape the immune system stamping on them? Well, it's because these abnormal proteins appear on the outside of all cells, and the cancer cells that we see have acquired mutations that enable them to hide. We don't see all the ones that didn't do that. They've all been wiped out. And there's various sort of mechanisms, but the one on the bottom right is PDL1, and you may know that from immunotherapy. And we did this in a review in 2019, and I summarise it in a quick picture. So here we've got in yellow, the mismatch repair deficient epithelial cell, which is not a cancer, it's just thinking about it, or potentially on the route to. And on the outside, its tissue type is presenting this abnormal protein in the red, and the T cell receptor in green is sticking onto it, and the T cell is thinking, right, I've found a cell to kill. So it sticks what's it's in, and it literally punches a hole in and kills that cell. That's why T cells are so good. So it's thinking of being troublesome, kill it. But if that epithelial cell, the cell in the crypt, can acquire a mutation at random, it doesn't do it with any sort of sense. It can express, for example, PDL1 on its surface. And so the lymphocyte comes up, and the epithelial cell has effectively grabbed it by the throat and said, you're not going to do anything silly, are you? So it's fought it to a standstill, equilibrium. And that's what's going on all the time. Okay. And if that goes on, it's only a matter of time before that cell acquires a mutation in another gene that then prevents it from showing the red, the abnormal protein on the outside, so it completely hides. It's gone into its little trench and it's put its steel helmet on and it's not showing itself. And then it can escape the immune system and potentially become a cancer. But the number of steps that have to go on to do that are a lot. And only a tiny fraction of what starts on the left gets to the right. So this tells us something about the processes that are going on, at least in Lynch patients, but potentially the rest of us with other cancers. So we've learnt an awful lot about what goes on in this. And I just find it absolutely fascinating that this is we've learnt what this is, and we've learnt it from you. And the value of studying people with unusual but rare and specific conditions, and I say rare because at the start we thought Lynch was rare, but we now reckon it's pretty common and potentially the most common inherited genetic condition, if not a cancer genetic position. So, quick now about WHO. So I'm appointed as one of the authors and now editors of the textbooks to which all pathologists in the world refer. So if the WHO says that this thing is a blue spotted what's-it, everybody has to call it a blue spotted what's-it unless they want to argue against it. So we have a good debate going. And in 2010 there was the 4th edition, and I was involved in doing the 5th edition. And this is a bit like the Observer's Book of Tumours. So within the 5th edition, which came out in 2019, there is a new chapter now on genetic tumour syndromes of the digestive system, and within that you will find Lynch syndrome. You'll also find familial polyposis, Purge-Jaegers and Uncle Tom Cobley and all. And that's very good. And breast tumours was the next volume on the list, and we spent a lot of work preparing a section on breast cancers in Lynch syndrome, but you won't find it in here. And the reason is because after considering all the evidence, we submitted our section to the editorial board, and the feedback was, well, as you pretty convincingly showed there was no risk of breast cancer in Lynch, we should not put this in this volume and confuse people. But we will let you produce a paper with our blessing, and we will sign it off as to presenting the evidence why you think this is the case. So we tried that, and we did that just before I was clobbered with COVID. And other people reject. They say, oh, there's a risk with MSH2. Yes, but there's a lot of MSH2 in the population. So if you simply test 1,000 women with breast cancer, you will find a lot of MSH2 mutations. Nothing to do with the fact they got breast cancer. So it comes back to that bit about the adenomas, the ordinary sort, turning into bowel cancer. Nothing to do with Lynch having caused it. It's just that if you've got Lynch syndrome, your breast cancer may acquire the spots of Lynch syndrome. that's what we think is going on. But there's an active debate. So it goes on. And we're going to produce a new volume purely on hereditary tumours, and the editorial board will be meeting later this year, and I'm on that. Paediatric tumours we've done, which includes this condition where somebody inherits a Lynch mutation from both of their parents, and they suffer from complete loss of mismatch repair, and it has all sorts of complexities and implications. And hopefully we'll get hereditary tumours out the last volume, which is a new one in the series, in either later this year or next year, we hope. Now, I was going to show Kelly Lloyd giving a talk on aspirin, but we've run out of time. So maybe we could fit that in later. So it's 10 minutes. It's exactly 10 minutes, and that would be good. So just to sum up then, we're understanding about Lynch and the immune system and how each tells us about the other, and how and why cancers develop in Lynch syndrome. The immune system as it works in the endometrium, in the womb, is very interesting because, as I said, it has to tolerate a baby but reject other things. So maybe that's why that is an area prone to cancer. We're getting it better with testing cancers. We're doing it better. Quality is steadily improving. Medical education, WHO classification. And, as I said, aspirin, understanding the barriers to why it's available to you, and all that. So I'll leave that there then. And by all means, come up and ask me questions, or indeed ask me on, email me, whatever, contact me through.